Hello, thank you for coming and meeting today to hear my pitch for our proposed study. My name is Samuel Booth, and we're going to be talking about understanding racial healthcare disparities, especially in regards to colorectal cancer. So, part of the issue is we have to describe the disparity. Colorectal cancer is the third most prevalent form of cancer in the United States. This is often behind lung cancer and breast cancer. Is often also one of the most morbid conditions, morbid colorectal cancers as well. Because of that, as we mentioned, there's a very poor 5-year survival rate. This means that from the time of diagnosis, only a few amount of the patients will still be alive at the 5-year mark. Colorectal cancer also disproportionately affects different populations. This means that some races or ethnicities may be genetically at a disadvantage. The literature has also shown that being of a lower socioeconomic class has also demonstrated a worse outcome for individuals who are diagnosed with CRC. This is currently thought to be that often those of lower socioeconomic class often have worse health care, or they have delayed access to health care, which then leads to a more poor prognosis, unfortunately. So part of the study is going to be to try and figure out what can we do to improve these outcomes. We want to try and create targetable interventions based off the data that we find from this study. And we're going to be specifically looking at vulnerable populations. So let's talk about our study then. For our timeline, we're going to be following individuals who we recruit for 10 years. And as you can see, it's going to be for a possible additional 5 years. This is because, say we have an individual who has been followed in the study and is currently in the 9th year, and unfortunately at the 9th year they become diagnosed with colorectal cancer. If they were only in for 10 years, we'd only be able to follow them for 1 year of their prognosis. So what we have is if individuals are diagnosed with colorectal cancer, we're going to follow them for an additional 5 years at that time, regardless of what period of the study they are in. As we talked a little bit about, our ideal population will be African Americans, and they're going to be aged 40 to 55. This is partly because the recommended colon cancer screening is done with a colonoscopy. Colonoscopies are generally done starting at now, most recently at age 45, or they can be done earlier if patients have a family history or they have a more genetic risk factors for colorectal cancer. So we wanted to start our population right at about that cusp where people would already starting to go for colonoscopies and start to undergo screening procedures. So for our individuals, our population, we're going to break that into 4 cohorts. We're going to be looking at first, as you can see, individuals with health insurance that did not develop colorectal cancer at any point. The second cohort will be individuals with health insurance that did develop colorectal cancer. The third will be individuals without health insurance that did not develop colorectal cancer. And lastly, our fourth cohort will be individuals without health insurance that did develop colorectal cancer. The reason why we're including this plus or minus element of health insurance is, as we mentioned earlier, socioeconomic status can often affect the outcome and the prognostic factors of colorectal cancer. So we want to include this as one of our variables which we're going to be examining. As we talked about earlier, individuals who develop CRC, we're going to follow them for an additional 5 years, regardless of where they are at that point in time in the study. And the reason for breaking up our cohorts as such is we want to be able to measure how much health insurance and the ultimate 5-year survival can differ between these cohorts. Additionally, we want to look at that data as well and compare it to the generalized literature and see if there are stark differences or not between our population that we're studying and the generalized population within the literature. For our statistical considerations, as we just talked about, the main object we're going to be going after is the 5-year survival rate of our patients. The recommended recruitment from a G-Power analysis demonstrated that we should have at least 110 individuals recruited to our study. We plan to hopefully recruit 150 individuals. The reasoning for this is so that if individuals leave at any point in time in the study, or if they become lost to follow-up, that we've created a small statistical buffer as well. We're going to be doing all of our analyses with a confidence interval of 95% and with a p-value that is statistically significant of under 0.05. Lastly, we're going to be looking at paired t-tests. Since our main subject, our main statistical study is going to be the 5-year survival. So we want to compare these averages between cohorts into the generalized data. One item we want to include within this study is community-based research participation, or CPBR. We would like to ideally work with the National Black Leadership Initiative on Cancer. This is an organization that has been working with African Americans and their predisposed genetic or socioeconomic or other various risk factors as well, trying to improve the overall healthcare access and healthcare availability to these individuals. We'd like to implement CPBR as well to work with community health workers. We feel this would be a great opportunity to network with local districts and neighborhoods, strengthen our commitment to the populations that we are working with, as well as potentially recruit and hire any individuals within this population for biostatistical analysis or other healthcare providers. Ethical considerations that we have to consider, of course, are the proper consenting process. Individuals should know that they can leave the study at any point in time and for any reason at all. Regardless of when or why they leave, they should understand that they will have continuity of care with their primary care physician or with their oncologist should they need one. And lastly, we want to make sure that patients fully understand what they're signing up for, that they will be with us for at least 10 years and will be getting continually access to the medical records. Last thoughts for us is that we want to ideally create this study so that we can create targetable interventions and start to work in a more preventative manner. If we can prevent colorectal cancer from even forming, ideally we can prevent more deaths, we can prevent less of a burden on our healthcare system, and ideally allocate those resources accordingly. Thank you very much for your time.